bit after. All right, I'm going to go ahead and start just so we have enough time to make sure we get time for questions and discussion at the end. I want to welcome everybody to CAB2 ChatnChew. And I want to just go ahead and jump in and introduce our speaker. But I guess before I do that, what I will say is please make sure if this is your first CAB2 that we have your email information. You can put it in the chat directly to Lori Long. We'll add it to our email list. The idea behind CAB2 is we would like people who attend to invite 2 people, and then that those 2 people then invite 2 people so that we can grow our reach and make sure that this important cancer-related information gets as widely disseminated as possible. So today we are excited to welcome Dr. Niharika Dixit. She is to the left on my screen at the top, but she's a medical oncologist with a keen interest and focus on cancer disparities. And for quite a while, she was one of only a handful, maybe 2 or 3 medical oncologists who were really holding it down at the San Francisco General, taking care of, care and coordination for a majority of patients who were either uninsured or just generally underserved. And I think it's important to acknowledge that she really worked seamlessly with the navigation program. And I raise that issue because sometimes physicians don't work well together with sort of seeming outsiders or have some resistance to that. But Dr. Dixit really understands that the team-based and community-engaged approach is really key to addressing the challenges faced by women with limited resources in their battle against breast cancer. She's been intimately involved in fundraising to support the needs of these communities more broadly, even while also leading the SF-CAN Breast Cancer Task Force and continuing her busy clinical practice. After the pandemic, she noted, and we had some conversations about women who were showing up with really advanced tumors and in fact metastatic disease where the tumor had spread to other parts of the body because they're afraid to get screened. Because of their fear of contracting COVID. Turning off my camera because I'm breaking up. So she's here today to share with us her perspectives on the role that community can play in continuing to combat late-stage disease while also fending off the global pandemic. Dr. Dixit trained at the Armed Forces Medical College in India and then did an internship in the Command Hospital also in India, trained also in obstetrics and gynecology to broaden her bandwidth. And then undertook internship in Baltimore at Good Sam, as well as St. Elizabeth's Medical Center in Boston, Massachusetts. She finished her hematology oncology fellowship in 2011 at St. Elizabeth's Medical Center in Boston, and then joined us here on the faculty at UCSF. And we are so, so grateful to have her and her dedication to making sure that those who are most deeply in need get both their, what they need in terms of screening and early detection, but also make sure that they really are held by the staff who take care of these folks at the San Francisco General. So I want to turn it over to Dr. Dixit. She's going to have about 20 minutes to give us a talk, and then hopefully we'll have some lively discussion. Please feel free to put questions in the chat while we're moving along, and the staff from the office will keep track of that and help feed those to Dr. Dixit after she's done. So without further ado, passing the baton to Dr. Dixit.
Thank you, Kim, for that kind introduction. Is it okay for me to share my slides?
Yes, please.
So as Kim pointed out that I work at San Francisco General Hospital, and COVID has brought home the disparities in stark contrast. Even though I was aware of it, things have just been even in sharper relief since COVID hit. And so I wanted to talk about some of these disparities. So in San Francisco, as part of the SFCAN Breast Cancer Task Force, there was work undertaken which looked at disparities within San Francisco. So if you live in San Francisco, where you live determines your stage at diagnosis. So when we really talk about breast cancer, we really think about zip code, not genetic code. So, for this particular study, Dr. Stava Gomez with the SFN task force actually divided the city in different neighborhoods. And what it shows here is that how high the risk is as compared to neighborhood, which is north. So the north neighborhood has the lowest incidence of higher stage at diagnosis. The northeast neighborhood has a higher stage at diagnosis as compared to north, so almost 1.64 times. If you live in southeast neighborhood, your risk of being diagnosed with breast cancer stage 2B or above is 1.7 times. And similarly in center west neighborhood and center east neighborhood, so sort of mission areas, Chinatown and the southeast neighborhood. So this work was brought home to us that we really needed to focus on the geographic disparities, because geographic disparities represent a lot of injustice, social injustice that has happened over the years, even within the city of San Francisco, that has resulted in these disparities in diagnosis and also in disparities in breast cancer outcomes. If you look by race and ethnicity and you look at rates by stage, if you look at racial and ethnic disparities, women who are racial and ethnic minorities are less likely to be diagnosed with early stage and more likely to be diagnosed with higher stage at diagnosis. And this number is per 100,000 population. So if you look at the numbers even by stage, I showed you the geographic disparities. Where you live determines your stage, but also what race and ethnicity you are also determines your stage at diagnosis. So if you're a racial and ethnic minority woman in San Francisco, then you're more likely to be diagnosed with higher stage at diagnosis. And, similar to that, this is the mammography use within San Francisco, which is if it is mammography use is shown. If you're red, then the mammography rates are low. So red, orange, yellow, those are lower mammography rates. Blue are higher mammography rates. So if you look at these mammography rates, you see that the mammography rates are lower in this area and the mammography rates are lower in this area. And similarly, the stage at diagnosis being higher, stage 2B and above, is higher in this area. Almost 30% of cancers that are diagnosed are stage 2B and above in this neighborhood, where mammography use is lower, and the advanced stage is much lower in this neighborhood, where the mammography rates are higher. So what I'm not saying is that the mammography use is the only thing, but it is something that we can intervene on and something that we can fix. So it's something that we can focus our efforts on in addition to everything else in improving care. So in 2020, when the COVID hit, there was shelter in place between March to April. And so there was no mammography going on anywhere between those months, between March, April, and May. And so in UCSF Health, when the shelter in place was on during March, April, and May, the mammography rates went down. So the blue line is the baseline mammography rate in UCSF Health. The orange line is 2020. And so if you look at the orange line, it goes down during the months of March, April, and May, but it goes all the way up and actually overshoots the baseline. So, there was already making up on the numbers of mammograms that were being done at UCSF Health. while in the San Francisco Health Network at San Francisco General Hospital, our numbers went down. This is our baseline, and our numbers went down and never really recovered to baseline, actually until October. So we hadn't recovered even in third quarter, and we recovered in October and we went down again. And let me show you what happened to our mammography numbers. So these are the baseline number at San Francisco General Hospital. And we went down, these are appointments in the solid and the scheduled. And so patients who were scheduled, it goes down between March, April, and May, as it was at the, and in UCSF Health and everywhere else, all the health centers. But we never really reach our baseline. Our appointments reach the baseline, but not our appointments ended. And then we go down again in January 2021. And actually, we were almost 50% of what our mammograms should have been at that time in January. So that we are really affected in terms of mammogram. We also had very high number of no-shows. So this is our no-shows, and this solid black line here is our regular number of no-shows. Our no-show numbers, and this is in percentage, were much higher than our have been. So I'm sorry, these are our no-shows. So they have been much higher with the circular dots. And so our no-shows are much higher than they have been in the past because people are not coming for their mammograms. And this I was seeing in the clinic because I at least anecdotally, because I won't have the data until another 6 months for 2020, I have at least seen a lot of women present with metastatic breast cancer, more than I've seen in my last 11 years. And definitely I've met patients who found a lump in March of 2020, waited till September to see us, and by the time we saw them, they already had metastatic disease. So it was really difficult for me personally to see this in clinic. And these are our no-show by race and ethnicity. And this is by sort of quarters in some ways, or during the different phases of the pandemic. And so the dark here is the show rate. The top here is the no-show rate. And so if you look at the no-show rates, our no-show rates are higher for African-American women across during this whole year. During stay-home order 1, reopening phase, stay home. But what's really concerning is that our numbers went down to 38% for completed mammograms and really high no-show rates. So our no-show rates are much higher in December to January 2021. So during different phases of pandemic. And so this has been really personally concerning to me because our no-show rates actually increased over the pandemic from our baseline. And COVID disrupted care. We did a survey of our cancer patients. And this is sort of our cancer patients are from the same neighborhoods that we are trying to target our mammograms to. And what our patients said, that there wasn't enough food, there wasn't enough money for medication, basic essential, not enough money for 22% of patients, and social isolation. So COVID really disrupted our care, but also our societal networks. And when we asked our patients, was there ever a time when you did not have enough money? 38.8% of our patients said that there was a time when they didn't have enough money for food. And I think this is really important because until we address these issues, we can't say that get your mammogram, because obviously that doesn't make sense. Patients didn't have money for monthly bills. They didn't have money for rent or house payment, about 22%. So this kind of just tells you that what the impact of COVID is on people's everyday life. It became not just a disease, but an existential crisis just from the economic aspect of it. So I think one of my goals to present this is how should we respond to this? And I'm going to sort of share with you what I have been thinking about, and I would be curious to hear what your thoughts are and how we can partner together, how we can work together, and to do this important work. So one of the things, the way I think about is sort of multi-level, improving care at multiple levels, so multi-level intervention, focusing on individual, focusing on healthcare teams and community. And, and that means improving individuals' care. How can the healthcare teams work better? And how can we work with the community to actually achieve better care for everybody? So at healthcare team level, we are reaching out to our primary care clinics on asking them who's getting screened, what does their report card look like. So we are specifically working with some of the clinics that serve our patients to actually get those numbers. We are also thinking about how to provide reminders to the primary care doctors who are seeing patients and provide them feedback on where their patients are. One of the things that has happened during COVID is a lot of care switched to telehealth. Almost 50 to 70% of appointments were being done by telehealth. But people were not thinking about mammograms at that time. I think a lot of care was just getting through things that need to be taken care of immediately. And people weren't really thinking about how to actually improve sort of, or to put in place things for health maintenance. And so, you know, we haven't really done workflow improvement with telehealth to actually include mammograms or healthcare screening or healthcare maintenance as part of that. We also want to make sure that none of the women who have an abnormal or incomplete mammograms fall through the cracks. So how do we improve that care? And then how can we do quality improvement projects that actually focus on these parameters of women getting screened and women making sure that they get care that they need? So an example of this is that we've been working with the Richard Fine People's Clinic in San Francisco Health Network. And we are actually doing outreach to specifically Black and African American women. And they can be scheduled directly into our mammography center. So their primary care clinic can actually schedule them. And then we give them, because we knew that transportation was a huge issue. So we included $40 taxi voucher and a $25 gift card. And I have to admit that a $25 gift card is not a big amount of money. It's actually nothing in what our patients are facing, but it is something that we could give to our patients that for their time, at least that they spend in coming to the clinic to get their mammography. And so that's what we did. In addition, they were doing screening for tobacco use, food security, and depression, so that we could do more intervene on some of these things also. We do have some preliminary data for these from this intervention, which is showing some preliminary results in actually increasing the number of screening. So that's what we're working at the clinic level. At the individual level, what we were thinking of doing reminders, incentive, one-on-one education, and addressing structural barrier. One example of that is transport, that we can actually provide assistance for as much as possible, because we know transport has become a really big barrier for many of our patients, because nobody wants to take 2 buses during COVID. And then some of our patients are also facing other issues, taking public transport. And so that's been an issue too. So at the community level, we are trying to hire a community coordinator whose role will be to reach out to community-based organizations to partner. Because I think the way I look at as a cancer doctor, I have a very cancer-focused vision sometimes, while people who are in the community are not thinking about breast cancer. They're thinking about other things. And as I pointed out, you know, our patients were facing a lot of other issues in addition to their cancer. So obviously, there are things that I need to get a better perspective on that. And then seeking solutions from the community to actually fix these issues. And understanding the needs of the community to be better partners and collaborators. So how can I meet meet the needs of the community, or how can we as a group meet the needs of the community, can be to actually improve some of these disparities. So my goals for the next year are that to improve mammography screening, especially in the neighborhood where the mammography use is low, prevent or eliminate delays in diagnosis, and prevent delays in treatment and improve patient experience as they go through our clinics, and make sure that they get the care that they need, or the best care that they need. And so I think that's my last slide. And I will stop sharing. And I see a lot of messages in the chat box.
Yeah, there's quite a few. So thank you so much for that presentation and for sharing that very local data. I think that captures the impact of the pandemic. Although I think when you get to some of the questions, you'll see that folks are wondering, is this pandemic related, or were these patterns already there? So I'm going to just call out a few names sort of in the order that the questions that they asked. I think Maria had a question about the clinics and how they opened or closed during the pandemic. I don't know, Maria, if you want to.
I was looking at the access, and I know that there was time, you know, when I was wondering if the clinic ever stopped providing services, or if they limited their mammogram screening being offered, and then how was that communicated to their patients? So was there times when a patient's actual appointment was canceled, and then how was it followed up to suggest that it was open again, or they had available slots? So I'm wondering if there wasn't some disparate treatment, both in it was canceled and then they weren't followed up with, or else the fact that there was possible that, you know, they maybe even went and then couldn't get the services and did not return.
So all screening mammography was not available between March, April, and May. So the first shelter in place, we completely closed down for doing mammography. And that was not just us, it was all through the Bay Area. And at that time, we were not doing any screening mammography for those 3 months. Nobody did any screening. When patients were canceled at that time, they were rescheduled. And I think that's what you see in other places, is that, you know, when I show you the UCSF health data that I have, is that they overshot because they got in everybody that needed to get in. Even though we rescheduled our patients, our no-show rates from 20% were up to 40%. So not only we never reached those numbers, our no-show rates were also very high. So we didn't get people in. And you're right that, you know, oftentimes, especially in a safety net hospital, how did we provide outreach to them? How did we make phone calls or things like that? We do have a system where the primary care clinic are informed about when patients don't show, and we ask them to do the outreach to their patients, but they will get a message that their patient didn't show for this appointment.
Thanks. I think Michael Shaw had a question about no-show rates as well while we're on that topic. Michael, did you want to? I'm not sure if he's still there. What he wanted to know was, were the rates for African-American patients the highest even before the pandemic? And do you think it's for the same reasons? And then do you have any data on no-show rates for men?
So it's correct that the no-show rates are higher for African-American women even before the pandemic. And as I showed you in those slides, even if you look at the different phases of pandemic, the no-show rates actually got worse over the course of pandemic. So before it was no-show rates were higher, but they even got even worse during the pandemic. That was the most impacted group in our data in terms of no-show rates.
But just to make sure, what's the difference between, like, I see that they increased over time, but it was always a point of a shortcoming within the systems of your clinic where apparently African-American women were not showing up. Is that correct, or is that?
Yes, so it is something, you're right, that, there is things in the clinic. There are things that we need to fix, probably in terms of clinic, in terms of our outreach to patients that we needed to fix anyway, even before the pandemic. Pandemic just made it worse. And I think also, we don't know why those numbers got worse, because I don't have data to say that why these numbers got worse over the course of pandemic. Was the risk perception higher or not? There were other things that became more important. As I showed you, that it was, all these housing concerns, transportation concerns, a lot of other things that were happening at that time. All of those could have contributed to it. It's just, I don't have data, so I just have to sort of think of it from that perspective.
So what you're saying is you haven't collected any data about the perceived risk of COVID in your patient population? Okay, because that was also another one of the questions. Do you have any data? Karen wanted to know something about telehealth. Is there any information about telehealth use by race, ethnicity to sort of help guide planning going forward?
I don't have data. I don't have data specifically on telehealth from the primary care clinic. I know that at one point, 70% of our visits were telehealth in primary care clinics. What I did learn when I was talking to the primary care clinics is that before the pandemic, it was actually somebody in person. So when patients showed up in person, somebody would look at their chart, see what's not there. For example, if they haven't had their mammography will be scheduled, and then they'll see their doctor. So some of this was being taken care of even before the patient saw their doctor. For example, the ME will tell the doctor that this patient hasn't had their mammogram, or even schedule them for mammogram, put in referral for them. With the telehealth, it was only the doctor who's making the call. There's nobody checking the chart before. So that's one of the things I wanted to highlight when I was talking about telehealth. So thank you for asking me that question, is that because in telehealth, it all fell on the physician themselves. And, oftentimes on telehealth, people try to take care of what's the most pressing issue, rather than sort of looking at overall health maintenance. And so I think some of these things fell through the cracks during that time, during telehealth.
Right, and part of the reason I asked that is also moving forward. I mean, I think that telehealth, provides huge opportunities, but it really comes with a danger that some of our less resourced patients with poor Wi-Fi access or who are less tech savvy, as we move forward and add more bells and whistles to telehealth, will be left behind if we don't leave those back doors open to traditional modes of communication. And so that's part of the reason also I brought it up, because I think it can be an access issue moving forward as more telehealth is adopted and normalized.
Definitely, I definitely agree with you. It requires actually two-pronged approach, at least. One is at the provider level, that if you are going to do more telehealth, how do you make your appointments more like they were in person, so that you don't miss things? For example, should an MEA check the chart before you call the patient to make sure that some of these things are done? Or maybe the provider themselves. So definitely those things have to be improved at the clinic level or the provider level. And I haven't seen anything that's sort of addressing that. And that's one of the things I've been talking about to our primary care clinics, is how to kind of, because I don't think we are going to go to 100% in person anytime soon. And so it's really important to focus on that. For the, and I do, we have, survey that we did for our cancer patients, we found that only 50% of our patients have a laptop or a tablet. But 70% of our patients have smartphones, which means that they can do telehealth. So there are two issues. One is that not having access to the telehealth, 30% of our patients still don't have telehealth. The second is that telehealth use also requires some training. And, you know, because I do some work with telehealth, so we are actually doing Zoom group medical visits for our breast cancer survivors. And even for patients who are Spanish speaking, we have been having 100% attendance, because we had a research coordinator who was able to spend 1 hour of her time per person to train people how to access Zoom, right? So we need that kind of training, because, you know, every patient should have access. Some of our patients won't be able to make these visits if they can't do telehealth. And so if telehealth is the only way that they are able to do this, then we do need to train people to do the telehealth, to log into the Zoom, to log into their MyChart, because this is also, you know, a big disparity if they're not able to do that. So it has those two sort of factors.
So staying on the topic of, you know, the physician can't really do it alone, and it won't potentially be effective as a one-person team. Isabel was wondering how you incorporate community health workers, and may have some additional comments on that. So how do you engage with a larger community-based team?
So I think the community-based team, one of the ways I think about is how to, I think a lot of women, for example, may not know that they can get mammograms even if they don't have insurance. And especially if they have a mass or a lump that they found, they should get the care that they need, whether they have insurance or not. There are ways to provide that type of care. And so one is that information. The other thing is that putting everything into perspective, sort of when we are discussing other health-related concern, breast cancer screening being a part of that. And I think the other big sort of opportunity I see is the community health workers training patients in accessing their MyChart or accessing their Zoom, so that they can actually do some of these visits, because our patients do use smartphones and are able to access them if they are trained. And so I think I do see a lot of opportunity from that perspective also, that, you know, if we can do some of our training, some of these trainings for our patients, that may be one way that our patients are able to interact more with their doctors, with their chart, have more information about their own health.
Isabel, did you have anything else on community health workers you want to add or ask?
Yes, thanks, Kim. Dr. Dixit, I think that the whole issue of community health workers is as a bridge between community and service, that is the clinic and the hospital, has become a major national issue. And I've heard people from Iowa to Alabama to, you know, Los Angeles talk about utilizing those community health workers. What happens is the lack of policy that supports reimbursement, so that you can't build it out. But as you were talking about telehealth, of course, we have seen Latino communities trying to readjust and adjust. And one of the conversations we had was a community tech worker that becomes part of that team, so that they can help these communities get ready for the telehealth visit and utilize your services, because they now have their LinkedIn, they're ready to go, they know how to access, et cetera. And this will truly help, I think, rural communities as well, where there's even greater problem getting to comprehensive care or cancer clinics and support. So I'm wondering if there isn't any urgency on the part of clinicians to join the fight, support a policy that really brings in a changed public health care system, engaging community health workers as part of a medical team, because they have been proving invaluable in many instances to create that linkage between those community members, their needs, their cancer issues, and the clinician. So I'm working on policy, both state and national, and I've heard people talking about it. But we also need to make sure that we don't nationalize this worker force, and actually it does not look like a community healthcare worker from the community. It looks like someone with a BA and lots of certification and so on and so forth. Anyway, I'll let you answer the question, but that's my baseline observation, that community health workers could have helped a lot of the medical system in the very early stages had they been utilized, trained properly, outfitted, and deployed. They could have really shifted some of those numbers, I think.
I think you're absolutely right. And, but one of the challenges is how to pay for these services or how to pay for community health workers. And I think as a health system and as a society, we haven't invested in these resources, which you correctly pointed out could have made a huge difference during this pandemic. But, even when we don't have pandemic, we still have other health conditions where community health workers could have made, can make a huge, and have been making a huge difference. But the challenge becomes is that even though we see the value, we refuse to pay for these things, right? And
well, the Biden administration did propose that they wanted to roll out 100,000 public healthcare workforce that included community health workers. And that was specifically targeting the pandemic, which is almost too little too late, right? But the whole idea is to continue to promote, just as you said, this idea of longevity, a reshaping of a public healthcare system to make sure that it is truly partnering with communities. So you're not rescuing them, but you're helping each other to get the job done.
Exactly.
If I can piggyback on that, I just think that one of the issues also is that we're not using the funds that we have to help patients with telehealth effectively. Many patients are very savvy, have done 10 Zoom visits, but they all get called before their scheduled Zoom visit. And I think if we could have an opt out of that, where when there is a scheduled Zoom visit, many patients have already had lots of appointments, they don't need that help. And then you could utilize the maybe too limited, but nevertheless, the resources that are dedicated to those patients that need it. And I think right now that's not being done. So, those funds could be stretched much farther if we could somehow distinguish between those patients who need it and don't.
So reallocating.
We don't have anybody calling patients before Zoom. The only place where I'm doing it is as part of a research study that I'm doing of group medical visits for cancer survivors. But when I make my clinic calls, I have nobody.
And I want to point out that, healthcare finance is very complicated, and the negative impacts of COVID has been that hospitals and healthcare systems actually are not generating the kinds of revenue that they would normally generate in order to invest in the kinds of programs that we're talking about that we need. And in fact, at the San Francisco General, and Dr. Dixit, please, add to what I'm about to say, some detail or back end, but the navigators who have been in play for 2 decades at the San Francisco General all got farmed out to jobs for COVID. And so they were no longer service navigators. And most recently, that whole group has sort of been decimated by the fact that no one can advance, get a raise, get promoted. And so they're going to jobs where they can, achieve their professional interests, but they were trapped and stuck in the county-based system. And the county was like, okay, everything's on frozen now because we're broke or more broke. So that complexity just, really adds to the problem of how you incorporate community. So you're right, Isabel, it had been incorporated a long time ago with different models that sort of that help outside of the institution. It might have been from being corrupted by the fact that hospitals are generating a lot of revenue. I wanted to ask, Dr. Hyatt had a question about whether or not some of these, the financial needs that you shared with us at the top of your talk, if those were ongoing prior to COVID, or are you aware of whether or not those got worse with COVID, or were they kind of the same? Comparison.
So our navigators and social workers do some screening for all our patients. So our social workers do distress screening, and our navigators do screening for our breast cancer patients. So I can tell you from breast cancer, our navigators just started telling us that this is what they were seeing even before we had this data during COVID. And so that prompted us to do some fundraising to specifically address these concerns. So we decided that, we will raise some funds to specifically assist our breast cancer patients with housing, with grocery gift vouchers, and with utilities. If they brought a bill that they couldn't pay for utilities, we'll pay it for them, no question asked. And so we did that during pandemic because we were hearing more about it. Our navigators was just telling us so. And then we got this data from our survey that not only were we were hearing from the navigators, but just became an even more pressing concern for us.
Yeah, I think people have seen that sort of across the board, and as the terrible combo is as people get sick, people may not be able to work, and then as hospitals and healthcare systems lose money, they lay people off. It's sort of a vicious cycle of unemployment, ill health, and then financial hardship worsening ill health.
Right.
It's sort of a trap. So we're getting to the end, close to the end. I just wanted to ask if you could comment on how folks could get involved who want to be, working in some of these spaces, either as community healthcare workers or some kind of support to wrapping their arms around women and helping them through this process as serving as a linkage. Are there any opportunities for that? And I also want to point you all to the chat. See it, Jill, our partner up in Mendocino, made the point that for telehealth, to support telehealth, there may be partnerships with local organizations like senior centers, for example, who can put in place a technology and have a technology bank for folks to use their services. So what are some other ideas you have for how people can get involved from outside the system?
Yeah, I think one is that I want to hear about what thoughts you have, what ideas you have about this, because I think of it from a really different perspective than you are, and I might be overlooking something that may be really obvious to you. So, those are some of the things that I think could be very helpful to me, your point of view and your perspective. The second is that how can I don't have, what I'm working on is building relationships with the community. So if you can help me do some of that, facilitate being a bridge for me, I think that would be really helpful, because I don't want to just show up there and say, I just want you to do mammograms, because obviously we know that's not going to work. But this is a concern, and I for me, but also for many other people, and we want women to be diagnosed earlier and to have their breast cancer treated successfully. And so to do that, I do need your help to make some of these bridges to the community that I don't have, or to introduce me, or to introduce my work and what I'm interested in. So I definitely look at that. And also how, especially in community health worker, for example, how can I best partner with them, people who are working with community health workers, especially because I'm going to have a community coordinator. How does that person work best? How can I have that person reach out to you and ask you some of these questions that I have?
So we will have on our evaluation that I hope people will stick around, an opportunity to express interest in connecting with you in that way. I'm thinking now and wondering, are your breast cancer task force meetings open to get that community input asking for now? Is that a place where that can happen? I know Juanita in particular was asking how can she help to provide some wraparound services for these women.
We do have our meetings at least every 2 months for the breast cancer task force. And so, you know, you're welcome to join our task force and give us ideas, your ideas, and help us do this. We welcome your representation on our task force.
So when folks fill out the survey, please let us know that you're interested in being connected to the breast cancer task force for SFCAN, or that you have interest in part of that. I know there was a question about mobile mammography. I think the answer is currently no, but Neha, you want to comment on?
I think the van has just started going out again. It had stopped during the winter surge and was going between the months of August and November. But it was at reduced capacity. Everything was reduced because you have to clean equipment and everything, and was going to fewer clinics than it usually does. So it's not in full form yet.
Great. I think I may have covered most of the questions. Do you have any zip code data if that determines access?
I think at the zip code level, the numbers are too low. And so that's why the city of San Francisco was grouped into these neighborhoods to kind of assess those numbers and actually look at some of the data. And that's why we don't have the zip code numbers, but we know the neighborhoods that we serve. We know the neighborhoods that, you know, if you look at the COVID map and if you look at the breast cancer disparities map, you can actually superimpose them. Because that's how disparities work. That's how healthcare disparities work. Because, you know, we ignored them, or we didn't pay that much attention to them as a society or as a healthcare system. And in COVID, it was something that actually we could see that these are the neighborhoods that were affected because of the fact that those social determinants of health at work.
Kim, Isabel here. May I share with Dr. Dixit what we say in the neighborhood? We can't go back to normal because normal is what got us here in the first place. And so when you're talking about disparities, COVID simply shone a big bright light on them.
Absolutely.
Right. And they are, you know, it's the same disparities we've been talking about in cancer. They're just happening in slow motion. Bob has his hand up. And then we're gonna put in the chat after his question, the survey link. So please click the link. It'll open in a new window for you. Fill out that survey so we could give Dr. Dixit feedback and also let her know and express interest in participating or getting engaged with some of the work that she's currently. Bob, go ahead.
Yeah, so first of all, Niharika, great presentation, and congratulations to you and the task force and Olivia and others for your work on the task force for San Francisco Cancer Initiative. It's really been great. You know, one of the other things that Scarlett and her team have been able to do with those maps is not just look at the areas that you showed, but to look at areas that are defined by supervisory districts, so political boundaries. And one of the ideas behind that was that the information could be shared with the supervisors for different areas where the need is greatest. So I see Carol Magruder on the call here. So she and Valerie Yerger, of course, did this kind of work when they were working on menthol cigarettes, and had a big impact on policy through the representative from the Bayview Hunters Point area that saw the impact of menthol in the African American community. So my question really is, has the task force considered looking at advanced breast cancer presentation by supervisory district?
That is a good question, and I will ask Scarlett's help
Okay.
in doing that, because I think that could be really meaningful.
Are you talking about county board of supervisors? Are you talking about county board of supervisors? Because they track with your SF-CAN maps. Are you talking about representation in the state legislature?
No, city and county.
Your board of, so city and county are merged. They're not city representatives. It's the county. So your board of, your supervisor on Walton in the area where everything is going in kind of the wrong direction. And he's very much, he's very engaged, actually. He's the person who reaches to us for COVID help. But maybe state legislature might be another place to go at it in terms of trying to secure funding specifically for cancer.
That's true. That's true. I was thinking of San Francisco.
Right. Can I add in, if you can hear me? So that was Malia Cohen back before Shaman Walton came on, and that's Baby Hunters Point and Potrero Hill, and that's where I grew up, and so I'm very tied to it. You know, my mother died from breast cancer, and she was a very healthy person who was very forward thinking, wheatgrass and all kinds of things before anybody ever knew about it. And the approaching it from, as we do tobacco, the political damage in Baby Hunters Point in particular, with the environment, the shipyard, the wastewater, you know, now they're rebuilding it. So of tying that into the process of educating people about getting them more motivated to actually go in and get the mammograms. And my mother got a mammogram because she was so healthy. She was at Southeast Center, and when they had it, she's been passed for 20 years, so this is a while back. And someone didn't come to the appointment when they had the mobile van out there, and the woman knew my mother who did the appointment. She said, "Come on, Ruth, come on and get a mammogram." And that was how she got it. Otherwise, she would have never gotten one until she had, you know, till she was stage 4. So it was caught very, very early. She had 10 great years and had great, excellent care at San Francisco General, you know, and UCSF, excellent care. And so people, you know, that support of that hand holding that we need, of incorporating that into getting people in to, you know, to get their appointments that they've made and make appointments that they haven't.
That's a great story, Carol. You ought to share that with Niharika. We'll write it down and get it in the SF-CAN website.
Okay, I'll do that.
Can you say something about male breast cancer briefly? I think we did have a question about male breast cancer.
Yeah, I saw that, and actually we do see, you know, we see about 100 patients per year for breast cancer, and we see at least 1 or 2 male patients every year. We don't have any screening for male breast cancer right now, except for awareness. And you know, I do understand that it's something that's not talked about a lot, male breast cancer. But I think the things we need to make sure that people know is that the breast cancer can happen to men. And also, it can also be associated with inherited breast cancer syndrome like BRCA1 or BRCA2. So even the prostate cancer history or pancreatic cancer history in the family becomes really important. So, you know, as not as the part of SF-CAN, but as part of our other genetic testing intervention, we are trying to test all men with prostate cancer to actually identify men who have BRCA1 and BRCA2, because a lot of time patients don't know their family history, or may not be aware or may not connect the breast cancer history to prostate cancer. So those are some of the things we're doing, but unfortunately I don't have a lot of you know, outreach or anything that other people are doing, but I would be happy to work with you if, you know, if you had some thoughts about that.
Well, I appreciate those comments, Doctor. I also, just a thought is, I keep thinking of those no-show rates for African-American women. And so for prostate cancer and men who are not showing up, we recommend that they take their female partner with them. We recommend that they encourage them into that same story, the story they've held and kept from other men, that you begin to share it with your female partner. And we're hoping it helps get men into screening earlier, get better care, because women ask questions men never ask. Oh, and whenever anyone hears cancer, they just stop listening. So having a good partner is always a good recommendation.
I agree. I think that's when we talk about community, but it's also family and
Yes.
and so all those. I think all our networks play an important role in improving breast cancer screening, like you pointed out. So especially, yes, I think partners have a very big role to play. Thank you for that suggestion.
So thank you so much, Dr. Dixit, for sharing your insights and your very, very clearly visible concern and commitment to communities who are struggling with not just cancer and COVID, but just resources and capacity to kind of do the things that we think, oh, you should be doing this. Well, social determinants matter. So thank you so much for such an excellent presentation. Really appreciate it here. Again, at time, so people can go ahead and hop off. But I do want to please encourage you to fill out the information that gives our speaker feedback, and also, again, an opportunity not only for you to figure out how you can participate further with these efforts, but also give us recommendations for what other topics you want to hear about at our quarterly meeting of the CAB2 Chat and Chew. Please also invite 2 people. We want to grow exponentially by 2 people squared every time. Thank you all so much for being on with us and for supporting the work that we're trying to do in reaching all of our communities.
Hey, Kim, do you know who's going to be the next speaker?
No, we take recommendation from this group.
Good, thank
So
you.
it'll depend on what comes through the evaluation. So please fill it out.
Thank you so much.
Thank you, Dr. Dixit.